It's a pleasure to introduce our next speaker, my colleague and friend, Hun Cho, who is not only a talented immunologist and myeloma doctor, but a guitar player and amazing comic sketch, too.
Thank you, Ajay.
Yeah.
Well, really appreciate the opportunity to speak with you today. Irene did an excellent job of giving an overview of the treatment for myeloma, and I'm going to drill down on one of the more specific aspects of what she talked about, which is high-dose chemotherapy and stem cell transplantation, or the so-called auto transplant. So we're going to start off with a question here. Have you had a stem cell transplant? Your choices are A, no, but I will soon. No, but I'm considering it. Or my doctor is discussing it with me. No. C, no, my doctor tells me I'm not a candidate. Or D, yes. Seriously? I'm more of a Zeppelin guy. Well, there's nothing wrong with Motown. Okay, so more than half of our people here have had a transplant, and then it looks like a substantial number are considering it. So let me start off with sort of a representative case. I made this case up, but it's pretty typical for the kind of considerations that we make. So a 65-year-old woman was diagnosed with IgG kappa multiple myeloma. Her ISS staging was 1 at diagnosis. She started RVD chemotherapy with her local practitioner and got a more than 90% reduction in the M spike. So this is the VGPR that Dr. Gobriel was speaking about. She was referred to a larger center for evaluation for high-dose chemotherapy and stem cell transplantation for consolidation therapy. She had grade 1 chronic renal insufficiency and well-controlled type 2 diabetes, and her initial chemotherapy was complicated by grade 1 neuropathy. High-dose chemotherapy and stem cell transplantation, or so-called auto transplant, based on our current data, this is the best chance for durable remission. It can be done as part of frontline therapy or at relapse, or both, which we'll talk about. And more patients are considered candidates than in the past. And this was alluded to earlier. We used to use age limitations strictly for consideration for status. But now we've expanded our considerations about what types of patients can go on to transplant. So what does this transplant mean? So first of all, the transplant is really not an accurate name, because really what it is, it's your own cells. So patient cells are harvested. So patients' blood stem cells are stimulated to go out of the bone marrow into the bloodstream and are collected, as was described earlier. These are the patient's own blood stem cells. Then the patients receive a high dose of a chemotherapy agent called melphalan, which is intended to maximize killing of the bad tumor cells in the bone marrow. And then because this is toxic to normal cells and the normal stem cells, after the chemo washes out of the system, we reinfuse those stem cells back into the patients in order to restore normal blood-forming capacity. So it's really a method to support very high doses of conventional chemotherapy rather than a true transplant. And that sort of concept is depicted here. There's this zone in the middle where we're trying to maximize the killing of the tumor cells, but there will be side effects on the bone marrow. So we're supporting the bone marrow through the chemotherapy by reinfusing healthy stem cells. Now, there's different types of stem cell transplantation. There's different sources and there's different processes. Now, the autologous transplant, which I just described, where the cells come from the patient, is the most common type. There is another type of transplant, the more traditional or conventional transplant, which is the allogeneic transplant. And in this case, the cells come from a donor. And that donor needs to be tissue matched to the recipient. And that's a different process entirely, with substantially higher risks and narrower definitions of eligibility. There's different sources for stem cells. So peripheral blood is the most common source of stem cells in the autologous transplant. Rarely we use bone marrow directly removed from the bone marrow for auto or allogeneic transplant. And then umbilical cord blood can be used for transplants, but this is only for allogeneic transplants. It's very rarely used in multiple myeloma. And then there are single transplant is the most common, so a patient undergoes one procedure. There has been a lot of research into so-called tandem transplants where 2 transplants are done within a certain time period to try to maximize the effect. There's what's called a mini allotransplant, which is a reduced intensity allogeneic transplant, and then full allogeneic transplant, which really is not applicable for the vast majority of myeloma patients. So how does it work? So patients undergo induction chemotherapy as described by Dr. Gobriel. There's usually 4 to 6 cycles, so between 3 to 5 months of treatment. And then the stem cells are collected from the bloodstream. We wait until after induction chemotherapy so that the bone marrow is cleaned out from most of the myeloma cells. And then the stem cells are mobilized with combinations of growth factors, most commonly Neupogen or Neulasta, but rarely some other growth factors such as leucine. Or we can use cyclophosphamide or Cytoxan, which is a chemo drug, to stimulate the bone marrow to mobilize stem cells. And then there's a newer medication called Mozobil, which blocks some of the adhesion molecules on the surface of stem cells so that they shake loose and go from the bone marrow into the peripheral blood more easily, which has greatly increased the efficiency of the stem cell harvesting process. Those stem cells are frozen and saved for when you come in for your transplant. Patients get admitted or get their high-dose chemotherapy, and this is with Melphalan or Alkeran. I think Evomel is a European name. And then 24 hours later, after the chemo is washed out, we thaw those stem cells and reinfuse them back into the patients, and then await recovery. So the stem cell collection, we typically try to harvest enough cells for 2 transplants. So that number or definition varies slightly from center to center, but we try to get enough for 2 transplants for 2 reasons. One is then we'll have a backup in case something goes wrong with the first transplant. And second, those stem cells may be used in the future for future transplant-based therapies if the patient needs them. As we mentioned, you can mobilize stem cells with growth factors or chemotherapy, and bone marrow is very rarely collected, except in the case of allogeneic transplant, where it is a little bit more common. And as Dr. Gobriel mentioned, there is an option for outpatient transplant. So up until recently, transplants were exclusively performed in the hospital. So patients would be admitted to the hospital, get the chemotherapy, get their stem cells, and then wait out their recovery for 2 to 3 weeks in the hospital. But for selected patients, so typically younger patients, patients who live near the hospital or can arrange for housing near the hospital and can come to the hospital every day for a blood check, for a vitals check, make sure everything's okay, they can undergo transplants, so-called outpatient transplants. So you end up spending a lot of time at the medical center anyway, but you get to go home at night and sleep in your own bed. And of course, if you're close by and there is a problem, you can get admitted to the hospital if necessary. But the goal is to keep patients out of the hospital, and so for certain patients, this is now becoming an option. And this is one of the many subjects that you can discuss with your healthcare providers when it comes time to make this decision. And as I mentioned, there are certain conditions that will require hospitalization even for patients who are getting the outpatient transplant. But about 60% of patients who are doing a procedure as an outpatient never end up going into the hospital, which is great. Okay, so what are the side effects of the high-dose Melphalan chemotherapy? So fatigue by far is the most common side effect. It is expected. There's many reasons. Low blood counts, the direct effects of the chemotherapy, loss of appetite, etc. So this is the most common side effect, and it can last up to 3 months. Nausea and vomiting, diarrhea, other GI side effects are very common. Not just because of the direct effects on the gastrointestinal tract, but the chemotherapy alters your taste sensation. Sometimes things will smell or taste funny or unusual. You may lose your appetite. It may lower your threshold for nausea. And then mucositis, which is painful sores in the mucous membranes, typically of the mouth, are a common side effect. And then low blood counts. So as I mentioned, the chemotherapy that we use is toxic to the bone marrow, and all the blood counts, white blood cell count, red blood cell count, platelet count will drop even to the point where the white blood cell count may drop to zero, undetectable levels for several days, which can be very unnerving, but that's why we do this typically in the hospital, so we can take care of any problems that arise. Patients may need antibiotics if you have a fever. You may need transfusion support for red blood cells or platelets, but typically around day 10 to 12 after the chemotherapy, the counts start to come up. A lot of these side effects will resolve, and people feel a lot better. And what happens after the transplant? Well, we tell, at our center and most centers, we tell our patients to plan on 3 months for recovery after the transplant. Does that mean you're going to be lying in bed for 3 months? Absolutely not. But you're going to need time to rest, regain your strength, recover your blood counts, and get back into the normal activities of your daily life, which is ultimately the goal. So that means taking care of yourself, eating well, getting back into exercise, taking precautions to prevent infections, including prophylactic antibiotics and antivirals. There are certain considerations. Do you have to become a hermit? No. But you have to take precautions if you're going to be in areas where there's going to be a lot of people or sick contacts, et cetera. You'll have regular follow-up with your doctor. And typically, it depends on the center. We usually do it around 90 or 100 days. You have a complete reassessment of your disease status to determine how well you did with the how much you responded to the transplant. And that information helps guide us for what comes afterwards. Not everybody needs chemotherapy after transplant. Not everybody wants chemotherapy after transplant, but there's plenty of data to tell us that some patients will certainly benefit from chemotherapy after transplant. So there's no universal standards. It's not a cookie cutter, one size fits all, but we do have some guidance about the kinds of things that we should offer to patients after the transplant. So there's a large number of studies that show that there's improvement in overall survival and progression-free survival for patients who get maintenance chemotherapy after the transplant. And most common maintenance therapy right now is Revlimid or lenalidomide at a low dose given without steroids. There are a number of clinical trials trying to understand how more intensive maintenance therapy can benefit patients. And there are some patients who will still have some measurable or active disease at the end of transplant, and full-dose chemotherapies for further consolidation is an important consideration at that point. But every patient is different, so based on the information that is gained when the restaging is done, patients and their caregivers will have a discussion about what is the best options that are available for you. So, is it still needed, and if so, when? Do you do it after you finish your induction chemotherapy, or can you wait until you relapse to get the transplant? So this is a very important question, and this is a question that patients often have for their healthcare providers. We have a number of studies, particularly the IFM and Dana-Farber studies, which are now reported or about to be reported. So this is a trial that asks specifically, is it better to transplant early or later? So patients were included in the trial, got RVD chemotherapy for induction, they got Cytoxan mobilized stem cells, and then patients were randomized 50-50. Half of the patients got their stem cell transplant as a consolidation after completing induction. The other half got a few more cycles of chemotherapy and went straight to maintenance and did not get their transplant until they relapsed. So this was really a great formal way to ask the question. This was a study that was done at the French centers, and there's a companion study that was done in the US, which has not been reported yet, but has completed. So what did we learn from this study? We learned that response rates and depth of response was better with the patients who got the transplant up front as part of their consolidation therapy. And in longer remissions were also reported with the early transplant. So on average, patients who had the upfront transplant had 50 months median duration of remission versus 36. But interestingly, the overall survival, in other words, the number of patients who were alive at 4 years, was not significantly different between the two arms, which tells us a couple of things. You get better deeper and longer remissions with transplant up front, but because of all the great options that are available to us for patients who relapse, overall, it's not making a huge impact on survival. So this is the kind of information that factors into the discussion when you have this with your doctor as to whether to do the transplant up front or not. And as I mentioned, there's a companion U.S. study that is now completed, and we're expecting a report any day now. The only difference is that the Revlimid maintenance was not limited in the U.S. study. It just was continued until progression of disease. So this study will add some very important additional information. Does the duration of the maintenance therapy make a difference? Okay, so we talked about, mentioned tandem transplant. So is there any utility to doing a second transplant within 90 days of completing the first auto transplant? There's been a number of studies, and the answer is not completely clear, particularly because a lot of these studies were done before the inclusion of both Revlimid and Velcade in the induction chemotherapy. So there was an IFM study that was initiated in 1994 looking at tandem versus single transplant, and similarly a European consortium study. Now, and then more recently, there were two other studies. So the older studies suggested that there was longer remission and better survival with tandem transplant, but the newer studies did not detect a significant difference. And so the jury's somewhat out on this. I think the consensus at most centers is that we do offer single transplant as a consolidation. There are certain considerations that can be made. For example, if there is a substantial disease burden after the first transplant, that may affect the decision whether to consider a second transplant or not. So I want to talk in a little bit more detail about this slide because I think it's a very important point. So although the title is for mini allotransplants, the reason that we study allogeneic transplant at all in multiple myeloma is because there were several case series that were published in the 1990s that showed that myeloma patients who underwent full allogeneic transplant, which is a very dangerous procedure, but nevertheless was being studied at that time, there was a small percentage of patients who were long-term disease-free survivors. So allogeneic transplant could result in effectively in cures for patients with multiple myeloma, around 20%, depending on the centers. The important things to note is these were very small studies. They were very selected patients. And the other thing to note is that, unfortunately, there was a very high risk of morbidity or mortality from the allogeneic transplant. So up to 50% of patients would experience a significant side effect or death within the first year after the transplant. So it's a very risky procedure, but there is a small percentage of patients who are cured. So this is why we're very interested in allogeneic transplant in myeloma. And this is why you're going to hear a lot about immunotherapy in the future, because allogeneic transplant is immunotherapy. When you put donor cells into a patient, the newly engrafting immune system can recognize the cancer cells as being foreign and kill them. And it has been shown time and time again that this graft versus tumor effect is where the real efficacy of allogeneic transplant comes from. But unfortunately, it comes at a significant cost. And not just in myeloma, but in other cancers where we use allogeneic transplant, there's a very high risk of either long-term complications or death from the procedure itself. So in an effort to try to address this, several clinical trials were initiated, mostly in the late 90s and early 2000s, to look at so-called mini transplants. So this was a lower intensity transplant that the hope was that the sort of older myeloma patient populations, patients who are going to have kidney failure and bone disease and low blood counts, that might be more tolerable to patients who are typical or myeloma patients. But unfortunately, what we saw again was that there was still significant mortality, and there was really no improvement in outcome over auto transplant-based strategies. So unfortunately, this is really still what we would consider an experimental therapy. We would not consider doing allotransplant for the majority of myeloma patients unless it was in the context of a clinical trial where we were testing new methods or different methods to make it safer or more effective. Now, there are a lot of clinical trials, as I mentioned, for maintenance or consolidation therapy after the transplant. This is just a few of them. And if you do decide to go to transplant, you should certainly discuss with your providers whether there's a clinical trial that would be suitable for you to look and see if there's something better than lenalidomide maintenance for outcomes. So there's a lot of clinical trials using different combinations of medications. The idea is that we want low impact, convenient therapies that will improve disease-free and overall survival. And immunotherapy is a hot area of research in the context of transplant for the very reasons that I just discussed with you. When we put the patient in an auto transplant, when we put your cells back into your body, you have to grow a new immune system. And now, because of the great advances in immunotherapy and other cancers, we have a number of different tools that we can use to try to sculpt that immune response so that it can recognize myeloma cells as bad and kill them. So we want to capture the allogeneic transplant response, but without the morbidity and mortality. And there are cellular therapies such as CAR T cells or marrow-infiltrating lymphocytes. There's donor lymphocyte infusion for patients who are undergoing allogeneic transplant, and there's a number of vaccine-type strategies underway to determine if we can shape the immune response in the newly engrafting patients to get after their myeloma cells. So the questions that you want to ask your doctor when you go for that consultation: are you a candidate for high-dose chemo and stem cell transplantation? When's the best time? Do you want to do it up front? Is there reasons to delay it? Does your center do stem cells transplant? If not, can you send somebody, can you refer me to a place that does? How many do they do? Do they do outpatient or inpatient? How long will you be in the hospital? What kind of changes to my lifestyle? And when do I go back to you for follow-up? And the medical aspects are only one facet of the transplant. It's a huge life decision. It has a great impact on your lifestyle and your daily activities. So you need support. You need to learn more about the disease. Ask your doctor about treatment options and side effects. Establish and maintain a strong support system. Your family and friends are going to be your support team as you go through these treatments and the recovery. Look for support groups where you can meet and speak with other people who are coping with the same issues that you are. And try to maintain some normalcy. For example, we have a lot of patients who continue to work while they're undergoing their induction chemotherapy. We tell people that the recovery time is 3 months, but I've had patients come back to me a couple weeks after their transplant and say, look, I was going nuts sitting at home. I'm putting on my mask and I'm going into the office a couple of days a week. And some people need to do that to heal. And there's everything in between. Whatever you need to do to maintain that sense of normalcy in your life, because that's the goal. And then travel, define realistic goals. After transplant, a lot of patients want to go on a vacation, and that can be achieved as long as you take certain precautions and do it in a reasonable time frame. And there's a lot of resources for you. The Blood and Bone Marrow Transplant Network, National Bone Marrow Transplant Registry, BMT Support Online, National Transplant Assistance Funds, and Bone Marrow Foundation. They have online presences, and you can reach them. And as Anne and Mary mentioned earlier, the MMRF has nurses available 5 days a week for consultation, and they're very good at these types of issues. So to conclude the wrap on the patient case, so the patient decided to go have stem cell harvested and then elected to do the upfront transplant for consolidation. During the transplant, the patient had low white blood count and experienced neutropenia fever during that time, which required intravenous antibiotics, but her blood counts recovered as expected. The fever resolved by 21 days, and she was discharged to home. The restaging assessment at day plus 90 showed that she had a stringent complete remission. In consultation with her physician, they decided to do Revlimid maintenance as a standard maintenance therapy. She did this for 2 years, and then she decided that she didn't want to do it anymore, and she was having some mild side effects, mostly gastrointestinal, from the Revlimid, and so in agreement with her doctor, she discontinued after 2 years. And then at 3 years post-transplant, she remains in remission. So this is a typical story. It's not everybody's story, and we have to be prepared
to shape the experience for each individual. So this is a decision that you make with your family, with your doctor, with your caregivers. And it still remains the standard of care, as shown by these recent clinical trials. Autotransplant is associated with deeper responses than conventional chemotherapy, and early transplant is better. And allogeneic transplant is still investigational. So thank you very much for your attention.
So we're actually running on time, so there's a lot of room for questions, and there are quite a few. So let's first start with the who. Should smoldering myeloma patients be treated, and if they start treatment early, should their stem cells be collected? And also, what if they're not being treated? Should their cells be collected?
That's an excellent question. So I'll try to address the treatment question first, then the stem cell collection first. So the definition of smoldering myeloma has changed quite a bit in the last couple of years, and it's an area of very active investigation. There are certainly patients who in the past would have been described as smoldering myeloma who we now consider active myeloma, and they should be treated based on current criteria. I think that there's a lot of opportunities for patients who have smoldering myeloma to get treated on clinical trials. I don't think there's a really strong rationale to treat patients outside of the context of a clinical trial because there's no data to date that suggests that any therapy improves outcome and overall survival, and we need to acquire that information. So if there is a clinical trial for smoldering myeloma that is available to you, that's certainly something to consider. If you're a proactive person, you don't like the idea of not doing anything, then certainly investigating clinical trial options is a very good option. So when to collect the stem cells, that's a good question. Right now, the standard is to collect stem cells after induction chemotherapy. And the rationale is you want to clean out as many of those bad cells as possible, allow your bone marrow to recover its normal numbers of cells and its normal architecture so that when you mobilize those stem cells, they're as normal as possible. To my knowledge, there is no clinical trial where stem cells were harvested from smoldering myeloma patients, but it stands to reason that if you have 10% or more plasma cells in your bone marrow, that may not be the best time to harvest your stem cells. So, again, I'm not aware of any clinical trials. It's an interesting question, but at this time, the standard is to collect stem cells after induction chemotherapy.
And so to follow up on that, how good a response does the patient need to have to induction therapy to collect? Does it need to be PR, VGPR, MRD negativity?
Right. So there's a large body of data that shows that patients who are in a VGPR, so 90% reduction in the monoclonal protein, or better, have better outcomes with transplant. That's older data, but that's the data that we have to work with. So we try to get patients to that 90% or better landmark. That's the goal, and for the majority of patients, we can accomplish this. But any patient who demonstrates a significant clinical response, so if a patient has had a prolonged course of induction or has had to try a couple of different types of chemo to get into remission, a partial remission in many cases is sufficient to mobilize stem cells and collect. And we can often incorporate the stem cell mobilization and harvest with a chemotherapy regimen. So for example, if a patient doesn't do well with triple therapy such as RVD or VCD, we may give a combination of chemotherapy agents based on something like Cytoxan, which we use for mobilization of stem cells anyway. So combination regimens such as dexamethasone, Cytoxan, etoposide, and cisplatin is often used both for treatment and to mobilize stem cells. So we can achieve two goals: reducing the amount of tumor cells and mobilizing stem cells with different types of combination regimens. But that's less common than the standard.
So moving to the actual collection process, what is the goal? How do you know you collected enough? And what's the measure of quality? How long are these cells good for?
So typically, so there's a marker that we can look at that's on the surface of stem cells. So as patients undergo their daily collection, a small sample will be withdrawn and sent to the lab, and they'll test for this marker as CD34. And our goal is to collect enough CD34 positive cells to infuse 5 million per kilogram of body weight at Sinai. And the number is slightly different at different institutions, but our goal is to collect 5 million CD34 cells per kilogram of body weight for the patient. So you can do the math for the average 60-kilo patients, et cetera. And as I mentioned earlier, we try to collect enough for 2 transplants. So 10 million per kilogram is our goal. These cells are sent to a lab where they're cleaned up and then put in a preservative that allows the cells to survive the freezing process. And then they're frozen in a controlled fashion over several hours and then put in deep storage. And those cells can remain healthy and viable for decades. So we've had patients who got collected in the 90s and now are undergoing a procedure that requires stem cells for support, either transplant or boost. And we've gotten those stem cells and they're just fine. So the current preservation methods are excellent, and those cells can last a long time. So even if you decide to get your transplant up front, if there's enough collected for 2 transplants, those bank cells are available to you for years or decades to come.
So if they are good for years in insurance, how many will they pay for? Why not collect for more?
Well, a lot of times we do, because the goal is 10 million, but with the growth factor and Mosabil-based regimens that we have now, we routinely collect 15, 20 million, whatever comes out in the bag. You know, sometimes patients are champs, and the first day we get 20 million, and that's great. And they're done after one day, and everybody's happy. And all those cells get processed and stored. So every patient is different. A lot of patients have tons of cells in storage. It gives you more flexibility. For example, you may decide if you have an excess of cells available just to give 10 million for that first transplant. It may speed up the recovery. So we don't necessarily design our collection regimens to get more than two transplants worth of cells, but a lot of the times we end up getting more anyway.
And you alluded to the processing of stem cells. Does anything additionally to remove the myeloma or anything else in the laboratory?
That's a good question. So there's a lot of research that's shown that if you really look hard, you can find myeloma cell contamination in stem cell grafts. But is that important? And the answer is no. So there were several clinical trials where they did something called purging. So after the stem cells are collected, they go through several steps where they remove any non-CD34 cells and retain only the CD34 cells. And so when they did the randomization, they had patients who had purged stem cells versus patients who did not have their stem cells purged, and the relapse rate was the same. So there was no difference in relapse or progression-free survival. What that means is the myeloma cells contaminating the graft were not the source of the relapse. The relapse came from myeloma cells that remained within the patient after the high-dose chemotherapy, after the stem cell rescue. So we know that there's very tough, very bad stem cell, the myeloma cells that can survive even the high-dose chemotherapy and the stem cell rescue. So a lot of our efforts are now focused on trying to get those cells with clinical trials, and our clinical research is focused on that rather than trying to clean up the graft, because it doesn't make a difference.
And so just one final question, which is kind of the take-home message. What is the typical progression-free survival after an auto with and without maintenance? And I think equally important, what is the patient's quality of life with and without transplant?
Right. So that's a good question. So the IFM study showed us that the median progression-free survival with induction and transplant is 50 months. So that's an average. The quality of life, it's for most patients, if you have your transplant, there's a 3-month recovery period. A lot of people go back to work after those 3 months or resume their normal regular activities. The maintenance chemotherapy is relatively low impact. You take 1 pill a day, if you don't have a lot of side effects with lenalidomide, you're in good shape. So the idea is to restore normalcy. So these are patients who are out living their lives, doing their normal daily activities. That's the goal.